Thank you, Dr. Jagannathan Srinivas, for immediately accepting urgent basis for doing this class on Saturday. Dr. Srinivas is going to talk on the febrile thrombocytopenia. He is the HOD of Critical Care, Amor Hospital, Hyderabad. He newly transferred to a new hospital. Wish him all the best with the starting presentation. Thank you,
Thank you, sir.
Please start the presentation.
Yeah, thank you, sir. So I will start with approach to febrile thrombocytopenia, and we are in that season also, febrile thrombocytopenia season. So we can discuss it based on our experience, and we can share our experiences than monotonous lecture. So a 48-year-old female presented with fever, high grade, with chills and rigors, 5 days. Taken treatment at local hospital with antipyretics and antibiotics. Fever still present, high grade, body weakness, nausea, decreased appetite, GCS is fine, and blood pressure is 100/60, temperature is 101.5, on tablet PCM 650 mg TID, and known diabetic hypertension since 5 years on antihypertension on medication. So immediately we have investigated her. She came with these reports: HB of 12, WBC of 5,000, platelets of 55,000, creatinine is 1.52, LFT was normal, serum electrolytes were acceptable. So just for a brief thing, fever is defined as elevation of the body temperature as a result of change in thermoregulatory center located in the anterior hypothalamus. And thrombocytopenia, we know that less than 1.5 lakhs. And basically fever is a protective thing. And also it sometimes, if it is unregulated, it can cause damage to the body. So additional history, do you want, sir? Any additional history? Anybody, please?
Additional history means what type of?
మీకు ఏమైనా డయాబెటిక్ హైపర్టెన్షన్ ఉంది సార్? ఇంకేమైనా హిస్టరీ అడుగుతారా? ఎస్పెషల్లీ రెసిడెంట్స్ ఎవరు ఉన్నారా జూనియర్ లెవెల్?
సార్ ట్రావెల్ హిస్టరీ కానీ మిస్ అయిన కేస్ హిస్టరీ, ట్రావెల్ హిస్టరీ కానీ ఏమైనా ఉంటుందా?
ఓకే, ట్రావెల్ హిస్టరీ గుడ్ సార్. ఇంకా
Medication history, medication is on an antiplatelets, anticoagulants.
Yes, medication history.
And all comorbidities, what is underlying disease?
అంటే diabetic hypertension ఉంది సార్.
All, this patient, okay.
No, this patient. So let's go into this history from our traditional teaching. So fever గురించి, స్పెసిఫికల్లీ ఫీవర్ గురించి మనం అడుగుతాం. డిఫైనింగ్ ఏ ప్యాటర్న్ ఆఫ్ ఫీవర్ మనకు MBBS లో ఉండేది కదా. ఫీవర్ ఎప్పుడు వస్తుంది, ఎలా వస్తుంది, ఎంత వస్తుంది, ఎన్ని రోజులు వస్తుంది, ఇవన్నీ అడుగుతాం కదా. సో జస్ట్ ఐ థాట్ దిస్ టాపిక్ టచ్ ఇన్ టు దిస్. సో కంటిన్యూస్ fever does not fluctuate more than 1.5 degrees Fahrenheit during 24 hours, but at no time touches the normal. So this indicates pneumonia, rickettsial disease, typhoid fever, CNS disorders, and falciparum malaria. Intermittent fever, when fever is present only for several hours during the daytime, it is called intermittent fever. Localized pyogenic infections, bacterial endocarditis, salmonellosis, miliary tubae, and gonococcal. And remittent fever, fever with daily fluctuations exceeding 2 degrees centigrade in 24 hours without touching the baseline. Endocarditis, rickettsial disease, and brucellosis. So relapsing fever, short febrile period, 1 or several days of normal temperature. Hot skin disease, brucella, rat bite fever, dengue fever, yellow fever, etc. Saddleback fever is biphasic with several days of fever, a gap of reduced fever of about 1 day, and then several additional days of fever, dengue, yellow fever, Orlando, tick fever, Rift Valley fever, and viral infections such as influenza, poliomyelitis, and lymphocytic choriomeningitis. So classical clinical pattern. So this is our
Lights are not moving.
Sir, move అవుతున్నాయి సార్.
Outlet.
Slides move అవ్వట్లేదు సార్. సతీష్ సార్.
సార్ అవట్లేదు అవటం లేదు. ఆహా
లేదు అవట్లేదు. ఇప్పుడు అవుతున్నాయి.
ఇప్పుడు అవుతున్నాయండి.
Okay sir. So these are the defining types of fever sir. So ఈ కంటిన్యూస్ ఫీవర్, ఇంటర్మీడియట్ ఫీవర్, రెమిటెంట్ ఫీవర్, relapsing fever, saddle back fever. These are the types of fevers we look into it. Now is a classical clinical patterns are masked by the use of antibiotics. Absence of classical pattern of illness should not rule out any other tropical infections. And geographical and travel history both within and outside the country is of vital importance. Sir, ఇది మన క్లాసికల్ టీచింగ్, బట్ డెఫినెట్ గా ఇది కంటిన్యూస్ ఇల్లనే ప్రెజెంటేషన్ చేయాలని ఏం లేదు. Like it may not present because most of the things in malaria, he is mentioning that the patient can have a continuous fever, patient can have low grade fluctuations ఉండొచ్చు అంటున్నాడు. బట్ localized pyogenic infections ki intermittent fever ఉండొచ్చు అంటున్నాడు. But we see it as a continuous fever. So a lot of this will give a better idea for us what type of fever, but we cannot 100% depend on this. So same thing he is telling, and people are also nowadays using antibiotics and also coming, not only antipyretics. So little this gives us an idea, but not to dependent whole on only on this. What do you think, sir? Satish sir?
సార్ మిక్స్డ్ ప్యాటర్న్స్ ఉంటాయి కదా సార్. ఇప్పుడు అంతా కూడా వీఆర్ నాట్ క్లినికల్లీ వాట్ ఎవర్ ద థియరిటికల్లీ ఎక్స్ప్లెయినింగ్ ది సాడిల్స్ ఫీవర్ ఇవన్నీ కన్నా we found that as a first hour low, one thing is patient anxiety, second thing is by default we start any patient comes with the fever with some antibiotic.
Yes sir.
So we don't simply take that it could be viral fever, don't start antibiotic అని అంత ధైర్యం మనకు ఉండట్లేదు నేనైతే, because we might miss something, because our tropical area there is a possibility of we are missing some tropical bacterial or rickettsial infections. అది
సార్ బట్ మోస్ట్ ఆఫ్ ద పేషెంట్స్ సార్, అంటే నా క్లినిక్ వచ్చే వాళ్ళకైతే ఎవరికైతే ఫస్ట్ డే యాంటీబయాటిక్ అయితే స్టార్ట్ చేయట్లేదు సార్. ఓన్లీ ఆఫ్టర్ 4 or 5 days if they are having fever, then only I am starting. I specifically tell them I am not starting an antibiotics, but I ask them to either review personally or by phone, online consultation after 3 days, and depending on that I am taking a call sir. But if they are already 5 days వరకు ఫీవర్ ఉంది, లేకపోతే ఏదో యాంటీబయాటిక్ చేసుకున్నాము అయినా ఫీవర్ వస్తుంది అంటే దెన్ ఐఎమ్ స్టార్టింగ్ అన్ యాంటీబయాటిక్, టెస్టింగ్ దెమ్ అండ్ స్టార్టింగ్ దెమ్.
అంటే బేసికల్ గా ఏంటంటే ఇప్పుడున్న ప్రెసెంట్ సినారియోలో జనాలు మన దగ్గరకు వచ్చేసరికి పక్కింటోడు ఎదురింటోడు చెప్తే ఒక ఎజిత్రోమైసిన్ లేకపోతే ఒక ఆగ్మెంట్ వేసుకుని మన దగ్గరకు వస్తున్నారు కదా సార్.
100% సార్, నో డౌట్ సార్.
అదే సార్.
సో హౌ డు యూ కన్ఫర్మ్ థ్రాంబోసైటోపెనియా? ఎనీవన్? ఒకటి సార్, మనము 2 మెథడ్స్ చేస్తాము. ఒకటి మెషిన్ లో మనకి థ్రాంబోసైటోపెనియా అని వస్తుంది. సో జైన్ ప్లేట్లెట్స్ ఆర్ నాట్ we don't see they count as a platelet. So always discuss with the pathologist to see for the whether the patient is really having thrombocytopenia or not, because we have recently one patient platelet count is 28,000 అన్నాము. సెప్సిస్ లో ఉంది, పేషెంట్ కౌంట్ 28,000 అంటున్నాము. బట్ దేర్ ఆర్ లాట్ ఆఫ్ క్లమ్స్ వేర్ దేర్. అగైన్ లేటర్ దే సెడ్ దట్ 1.8 lakhs. So pathologist we ask them to look into it. So always confirm with the peripheral smear with the help of a pathologist. But other types of thrombocytopenia is there. One is but machine, most of the times machine gives the correct number, but the next confirmation step is with the pathologist. So that is the reason why it can be a Thrombocytopenia can be through 4 processes. One is artifactual, that is due to machine, so always confirm with the pathologist. There can be a deficient platelet production, or it can be abnormal pooling or pooling of platelets within the body, or a platelet destructions. So always check for the second time. Sir, how do you approach the patient with now the combination of a fever and thrombocytopenia? What comes into your mind? So we know that a practical is syndromic fashion is most important to enable the clinician to have a plan for treatment. Although it is anticipated that syndromic approach would not be able to cover atypical presentations, but can serve as a good guide for initiating therapy in critically ill patients. So just like what we have gone into the history, similarly in this also syndromic approach will help us. Both it is having a clinical thing and the thrombocytopenia. So we'll not go into much into a clinical things, but we'll go into the most common looks like a what we test is dengue, malaria, leptospirosis, rickettsial infection, sepsis, and meningococcal infections. Anything you will add, sir? Sachi sir? David sir?
Yes, sir. Common things we will discuss: tropical fevers.
Yes.
Four fevers, sir: malaria, dengue, leptospirosis, scrub typhus. Four
Yes,
fevers.
sir. Yes, sir. Vijay.
Sepsis
So-
can cover na? Sepsis with thrombocytopenia.
ఏదన్నా
అంటే most commonly seen sepsis with thrombocytopenia.
Yes, sir. మనకు sepsis patients వస్తాయి. So we also see thrombocytopenia, most common. Even juniors ఉన్నారా? What test they will do for? First we'll go with malaria. What test they will do? ఎవరు ఉన్నారా? సార్ ఉన్నారా మన దాంట్లో జూనియర్స్?
Hello, sir. Good morning, sir.
గుడ్ మార్నింగ్ చెప్పండి.
Sir, QBC చేస్తాం malaria.
ఓకే గుడ్.
And
ఇంకా?
peripheral smear also we'll do, sir.
ఓకే ఇంకా గుడ్.
Parasitic loads.
క్యూబీసీ
Parasitic load.
పారాసైటిక్ లోడ్ అంటే ఇంకా పెరిఫరల్ స్మియర్ అంతేనా?
అంతే
Yeah.
థిక్ స్మియర్ థిన్ స్మియర్ సార్. క్యూబీసీ
అసలు మోస్ట్ కామన్ గా మనం చేసేది ఏంది?
మన
QBC.
క్యూబీసీ అండ్ థిన్ స్మియర్ సార్.
షూరా?
We
మనం
usually
చేసేది
do
కార్డ్
that,
టెస్ట్
sir.
యాంటీజెన్ కార్డ్ టెస్ట్.
కార్డ్ టెస్ట్,
మనం-
పారాసైట్ వి అండ్ ఎఫ్.
ఎస్ సార్.
సో ఏది బెటర్ అంటారు?
Confirmatory always makes QBC and for parasitic load it is the microscope examination thin smear sir. But antigen I think it has a more cross reactions are there. I think antigen card test.
ఇంకా అసలు ఏది తక్కువ పారాసైట్స్ ఉంటే ఐడెంటిఫై చేస్తుంది? క్యూబీసీ చేస్తున్నాం మనం ఇప్పుడు? చేస్తున్నామా? తక్కువ పారాసైట్స్ ఏదంటే బెటర్ ఐడెంటిఫై చేస్తుంది? లీస్ట్. మనం ఇప్పుడు ప్రస్తుతానికి మనం అందరూ అదే డయాగ్నోసిస్ లో ఉన్నాం.
PCR sir. PCR
తర్వాత
antigen antibody.
ఓకే,
QBC.
లెట్స్ గో ఇంటు దట్ స్లైడ్. యా, థ్యాంక్ యూ సురేంద్రనా.
అవును సార్.
వెరీ గుడ్ ఆన్సర్స్ బస్. ముందు చెప్పింది ఎవరు?
Sir, Tripti, sir.
యా, గుడ్ ఆన్సర్స్. యా, విల్ గో నౌ. స్లైడ్ కనిపిస్తుంది కదా?
Yes, sir.
థిన్ స్మియర్ అయితే 500 పారాసైట్స్ పర్ మైక్రోమీల్ ఎంఎల్. ఓకే, థిక్ స్మియర్ అయితే 50 parasites per micro-ml. QBC అయితే 100. Rapid diagnostics test, what we do most commonly, parasite V and F అయితే 100. PCR అయితే 5. సో మనము థిన్ స్మియర్ మీద డిపెండ్ కాలేము బికాస్ పారాసైట్ లోడ్ హ్యాస్ టు బి మోర్. థిక్ స్మియర్ రియల్లీ అది ఎంతవరకు చూస్తారో తెలీదు. క్యూబీసీ కి ఆర్డిటికి ఆల్మోస్ట్ ద సేమ్ 100. సో ర్యాపిడ్ డయాగ్నోస్టిక్ టెస్ట్ చేస్తే సరిపోతుంది, ఇంకా మిగిలిన చేయాల్సిన అవసరం లేదు. ఇఫ్ ఇన్ డౌట్ యూ కెన్ డూ అ థిక్ స్మియర్ వన్ బికాస్ 50. PCR is, we don't do PCR for malaria commonly. So a lot of people, if the rapid diagnosis test is positive, they again ask for QBC, they ask for thin smear, thick smear, ivanni. So we need to know what to ask. That's the reason why I have put as a parasites per micro ml, so that we'll have an idea, not to undergo confusion. Now, as Dr. Surendra mentioned, rapid diagnostic test can be positive even though there is no active infection, because మనం PCR చేసాం కదా. COVID test చేసినట్టే if suppose some dead, కొంచెం డిస్టర్బెన్స్ వస్తుందండి, some dead malarial parasites are there in the vasculature also. This rapid diagnostic test can be positive because of this antigen. So there, suppose especially in as per Indian government, patients who are from not having from especially from Adilabad district, Srikakulam, Vijayanagaram, these districts, the people come with recurrent fever, even though if the malarial RDT is positive, and you have a doubt that this is not malaria, you can ask them to undergo thick smear, and you need to tell the pathologist to check into it for a confirmation. So this is from the malaria. Any questions? Okay. So now we'll go to dengue. Dengue enti? Ela how? Any questions from malaria?
No, sir. Thank you.
Yeah, we'll go to clear undi kada idi.
Yes, sir.
Yeah, we'll go to dengue. Dengue, how will you diagnose? డెంగ్యూ ఏం చేస్తారండి టెస్ట్లు మనం?
Sir, NS1, IgG and next is PCR, sir.
PCR, IgM కూడా చేస్తాం కదా?
అవును సార్, IgM, sir.
Yes, sir.
IgM, NS1 and
ఎప్పుడు చేస్తాము?
PCR. NS1 first week of illness, IgM if patient presented after 5 to 6 days of illness, and PCR makes good diagnosis.
Okay, fine, good. So
when is IgG positive?
Sir,
When will become IgG positive?
IgG 1 to 3 months.
14 days. 14th, third week, after third week.
Sir, see here, if you see this one, initial course of dengue fever, the first 3.5 days is white one. After that, it is 3.5 days to 6 days is a little yellow ఉంది, yellow to orange. తర్వాత 6 నుంచి 10 days వరకు మళ్ళీ వైట్ ఉంది. ఫస్ట్ 3.5 days, see, temperature is high, dehydration is more, can cause organ impairment, hematocrit is low, okay, and here platelets are normal, viremia is high. So this is the phase where this NS1 will be positive. So NS1 will be positive when the viremia phase, that is around 3.5 days మాత్రమే NS1 will be positive. Next, for 3.5 to 6 days, there will be temperature will be down, there can be organ impairment, or because of the capillary leak, shock, bleeding undachu, and platelets are down after 3.5 days, and patient can become more critical. So Here what happens here, IgM will start rising and later IgG will pick up. And next phase is reabsorption phase, fluid overload phase or organ impairment also. After 6 days, that means for the next 3.5 days after that, the platelets start increasing. And during this phase only, critical phase, we monitor hematocrit, where it will be very high because there will be more of capillary leak and organ impairment will be there. So there may be a phase of 3 to 5 days where sometimes dengue is negative, like NS1 will be absent, will not be reactive, and also IgM also may not rise at that time. Usually it takes 5 days, 3.5, 4 to 5 days. So there is a crucial period where NS1 is negative and also IgM also is negative. So there little difficulty. So take a careful history, and we can again repeat the test IgM if required if the patient is in 4 to 5 days of period. There we can repeat a IgM after 2 days of fever. So here we know that the treatment, I'm not going into the treatment aspects. This is a most common thing we need to understand. Okay, is it clear? Then we'll go to the next slide. Any questions? Dengue?
No, sir.
Yeah. Let's go into the leptospirosis. So we know that leptospirosis has 3 phases: anecteric, icteric, and severe leptospirosis. I am not going into details. So how will we diagnose this? What are the tests we do for leptospirosis?
Serology testing, sir. Antigen antibody serology testing of urine, blood, and CSF, sir.
Okay.
Also, we can tissue we can demonstrate, sir, in by fluorescent markers.
Okay. Fine.
PCR testing, sir.
Huh?
PCR testing, sir.
Okay. So this is one of the most important things. The first week, okay, we can do a blood and CSF microscope, and the density of parasites should be 10 to the power 4 per ml. So they do a dark field microscopy, and they tell in the first week. So in Apollo, we used to do this first week of fever. We send for a dark field microscopy, and with the help of microbiologists, they examine and they tell us whether it is a positive or negative. But if you are going for a urine for dark field microscopy, then it is in the second week. QBC, blood and CSF in the first week, urine in the second week. Okay, microagglutination test. Okay, blood 2 to 4 weeks and is up to years also it is positive. ELISA, if you take ELISA, then it is around 1 to 2 weeks. It will take, and PCR it is in the first week. So these are the things we look into it. So usually we can do a ELISA or a dark field microscopy also we can do. Most of the people don't do a QBC. We can send for a dark field microscopy or IgM. This ELISA test in the first 1 to 2 weeks, it will be positive. Okay, any questions? So scrub typhus, it also presents like a sepsis, and the presence of an eschar supports the diagnosis, but it is variably present. We know most of them, any patient coming with fever, to completely examine the body, so that if there is an eschar, then we got a diagnosis of the scrub typhus. What test we do?
The wheel Felix test.
Felix test.
It's a serological test, but nowadays indirect fluoroscopy, fluorescent IFA test is done, sir. It's a mainstay, but the definitive diagnosis is PCR. It can detect it in very early stages of scrub typhus, and biopsy is diagnostic.
Okay.
Eschar.
So wheel Felix test, okay, blood. It is only a test where it's a rickettsial diseases. It is not specific to scrub typhus. The rickettsial diseases, it is positive. And immunofluorescent assay and ELISA IgM, this can be positive in the first week. Okay, PCR, as soon as possible, we can do PCR test, and it will give early results also. This is actually the first week. This is not 3 hours. Okay, fine. So this is about the scrub typhus. So most of the times wheel felix is positive. If the wheel felix is positive, don't think that it is only a scrub typhus is positive, because it is non-specific test. So IFA and ELISA can be done in this patient, and PCR also can be done. And tissue also gives us a diagnosis. Next is sepsis. As David sir has already mentioned, the sepsis is one of the most common type of thrombocytopenia is mostly seen in sepsis, because thrombocytopenia we call it as it is less than 1.5 lakhs, because most of the patients will have this low platelets, but usually alone thrombocytopenia will not be there, so it will be associated with some other organ failure, and usually these thrombocytopenia will not be severe, so that we may not concentrate much. So usually around very severe is 4.8%, mild is almost 50%, moderate is 32%, 13% is severe, very severe is 4.8, and usually around 25% it is associated with DIC, is thrombocytopenia in this patient, and resolution of thrombocytopenia hospital discharge is approximately 60%. So this is about sepsis. And meningococcal, blood cultures, CSF if required, and PCR by DNA is okay. So from this, fever with thrombocytopenia, dengue, malaria, lepto, scrub, sepsis, and meningococcal infections we discussed. So let's go into the non-infectious causes. What can somebody suggest the non-infectious causes of thrombocytopenia? Evaluate some. Suppose if we evaluate this all in the first week, it is negative. Next 10 years, some.
Sir, first it is drugs. Drugs. Next, it is extracorporeal. It could be dialysis or ECMO lines, or could be cardiopulmonary bypass. Or next, if it could be non-infectious, it can be the vasculitis crisis can cause the thrombocytopenia. Next, antibodies.
MDS,
Definitely
MDS.
antibodies.
Hello.
Sir.
MDS.
Yes, sir.
Yes, sir.
That is a bone marrow failure. That is a decreased production. One is destruction. Destruction could be the antibodies, and there could be the antibodies from the drugs, and there could be the MAHA, that is hemoagglutation microangiopathy, the TMS, the TTP and HUS. Next could be the extracorporeal dialysis lines or clotting lines or ECMO and CPVs.
Okay. Okay. Yeah. So it can be destruction or consumption, life-threatening emergencies. So we see TTP, HUS, immune thrombocytopenia, drug-induced thrombocytopenia, heparin-induced thrombocytopenia, and DIC. Okay. So these are the some of the common things. Okay. Let's look into it. TTP. So again the cause of TTP is because of infections, drugs, malignancy, autoimmune, where Adams 13 binds to platelets and cleaves von Willebrand factor, so that there can be a consumption of the platelets because of injury to the wall, microvascular wall. So mostly idiopathic, but infections like Shigella, HIV, strep pneumonia, and drug-induced like quinine and chemotherapy can happen. So what are the required? So microangiopathic hemolytic anemia. This is usually with thrombocytopenia. Usually we'll have a microangiopathic picture on a peripheral smear, and the patient can have a fever, thrombocytopenia, or a kidney changes and neuro changes. So TTP will have more of neuro changes, and HUS will have more of AKI changes. And the most important thing is coagulation tests are normal in this, and hemolysis or labs are positive, and if you test it, Adams 13 activity will be less than 10%. So this is like an emergency. We see most of the times arterial ischemias in this patient and multi-organ failure. They rapidly progress to multi-organ failure and they die. So urgent plasmapheresis is required. Steroids can be used, and rituximab can be used, but this is on the later stages. The urgent initial treatment is plasmapheresis is the initial treatment of choice in this patient of TTP, HUS. Any questions? Chat lo mana Satish sir పెట్టారు. ఎష్కార్ ఆఫ్టర్ 10 to 14 days only అండ్ సిఎల్డి. సార్ మరి పేషెంట్ యాక్టివ్ ఫీవర్ అప్పుడు కూడా ప్రెజెంట్ చేస్తారు కదా సార్ ఎష్కార్? సతీష్ సార్.
సార్ చెప్పండి
సార్ ఇది దే ఆల్సో ప్రెజెంట్ విత్ వైల్ దే ఆర్ హ్యావింగ్ యాక్టివ్ ఫీవర్ కదా సార్ అరౌండ్
Eschar is a late presentation, sir. Most of the patients, Eschar develops only after 10 to 15 days. Having Eschar is good, but by that time, it is not an initial diagnosis of finding.
Okay.
And it rules in, like if you find an Eschar in a patient, mostly it is something related to Rickettsial infection, more so scrub typhus. But not having Eschar does not rule out Rickettsial infection.
Yes, sir. Yes, sir. Agree, sir.
Yes, sir.
So DIC. So there are two types of DICs. One is acute and chronic. And acute is we see in sepsis, trauma, AML, because of AML. And chronic is usually during malignancy, where there is usually thrombosis and not bleeding, the procoagulant, which is constant production and consumption issues. Because we see low grade DIC in chronic malignant patients. DIC clinical findings, we see PT, APTT high, low fibrinogen and platelets, and high D dimer. And if there is a bleeding, we give a replacement factors. And as I mentioned, that differentiation between DIC and TTP HUS is only this coagulation factors are the main things which differentiate it. Immune thrombocytopenia, inciting event causing autoimmune autoantibody formation, malignancy, rheumatological diseases, viral or bacterial infections like HIV, hepatitis C, CMV, varicella zoster virus, sometimes H. pylori, gram-negative bacteria, and molecular mimicry to GP2-3A receptors and platelets, and diagnosis of exclusion. And drug-induced thrombocytopenia, platelet destruction, medication-induced changes in antigen creating an autoantibody, platelet production, megakaryocyte death or decreased production. Initially about 1 week of a drug to start. Usually beta-lactam in the first week. Usually beta-lactams, vancomycin, linezolid, rifampicin, anti-epileptic drugs, and quinine. Treatment is the removal of stopping the drug, because when we see the thrombocytopenia, where all the other things are ruled out, then look into the drugs which are causing it. You can change into other medications, and you stop the drug and recovery, if it is a drug induced, if you are thinking of a drug induced thrombocytopenia, it takes time for the recovery of platelets, because as soon as you stop, it won't immediately next day or after 2 days it will recover. It takes minimum 1 week to recover. So that indicates that, and sometimes some weeks also it will take for a drug induced thrombocytopenia to recover. Evans syndrome is an autoimmune hemolytic anemia associated with thrombocytopenia. Look for other autoimmune diseases like SLE, HIV, HCV. Usually treat underlying cause or steroids. The head, we all know that heparin-induced thrombocytopenia. It can develop PF4 released by platelets during activation complex with heparin. IgG antibody binds to PF4 or heparin complex. And we know it is characteristic of 4 T's. One is thrombosis, venous more likely than arterial, drop in thrombocytes by 50% within 7 days. Sometimes around 5 to 7 days it will start dropping by 50%. Sometimes it can be early than this, by having less than, if the patient is exposed to heparin the last 100 days, then it can happen on the second day only. The patients can have a thrombocytopenia, and there are no alternative causes. Then this indicates that it can be a hit. So these are the 4 things we look into this characteristic features of a hit. And we do hit antibodies, that anti-PF4 antibodies. Sensitivity and specificity is good for these patients. And if the patient thinks of hit, then we need to start on the other agents like non-heparin anticoagulants like renal dysfunction, ergotropan, bivalirudin, liver dysfunction. We can do fondaparinux. And long term, when the platelets are more than 150,000, and if there is a thrombosis, then we need to start warfarin more than 6 months. And no thrombosis, then we need to have a warfarin of 3 months. And as David and Surendra was mentioning, bone marrow dysfunction, this is the most important thing. It can be a MDS, it can be leukemia, PNH, and infection, alcoholism, nutritional deficiency, and ITP, and also malignancy extending into the bone marrow. These all we need to look into it. And I have a patient recently who has a fever, thrombocytopenia, treated by one of the RMP for almost, he's having a mild fever, mild to moderate fever, and he has platelets of around 75-80,000. Then after 10 days or 15 days, he referred to me. So he is having mild fever, and he is also having anemia, around 9. Hemoglobin is 9, and having 75 to 80 of platelets, and WBC was little around 25-30,000. So we evaluated for all the other causes. So last 15 days fever, so evaluated, and I checked for peripheral smear. At the peripheral smear, there are a lot of abnormal cells. Then admitted into our hospital, and then we evaluated him completely. Then turned out to be AML, and so he has started on chemotherapy. So we need to cautiously look into the things, evaluate, and look into all this. So evaluated for nutritional, any deficiencies are there, vitamin B12, thiamine, and all these things we looked into it. He's also, he doesn't take much alcohol, but he has a history of alcohol intake. So finally, he landed out to be an AML patient, and he is on chemotherapy. Day 7 finished, and he is stable with neutropenia and thrombocytopenia, low platelets, and he is on blood transfusions. So this is one of the acute causes of thrombocytopenia. So when this is an ICU data from 2016 Indian Journal of Scientific Study. So then in 61 patients of thrombocytopenia, I looked into the data of patients who has a diagnosed like a malaria, dengue, lepto, and these diagnosed types of fevers and having thrombocytopenia. But I also thought of having a data fever with thrombocytopenia. What are the diseases? So this is one of the paper I got. It says that unspecified fever, 61%. There is no diagnosis. 61% of the patient with thrombocytopenia, they don't have a diagnosis. Dengue, 20%. Acute fever with MODS who responded to doxy, so they are thinking of scrub, 6.6. Sepsis, 8%. Malaria, 2%. And typhoid is 2%. So major chunk of patients are not having a diagnosis with the thrombocytopenia, fever with thrombocytopenia in the ICUs. So we need to evaluate for it, and we need to look into the causes of fever with thrombocytopenia. So these are the, in nutshell, these are the causes of fever and thrombocytopenia. Infections like dengue, malaria, leptospirosis, scrub typhus, rickettsial infection, there is sepsis, meningococcal infections, and non-infectious like TTP, HUS, immune thrombocytopenia, drug-induced thrombocytopenia, Evans syndrome, heparin-induced thrombocytopenia, and DIC, and non-infectious with the bone marrow related or the other systemic things, MDS, leukemia, PNH, infection, alcoholism, nutritional deficiencies, and malignancies. Thank you. Questions, please. Sir, over to you, sir. David, sir. Sir, Satish, sir.
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 Sir, a very common presentation, sir. Most of the times we come across the situation like patient within particularly in infectious months like July నుంచి November వరకు. We see patient comes with a fever, there is a mild transaminitis and early AK, mild elevated creatinine, maybe plus or minus rash and altered sensorium. So most of the patients, so we need to have a syndromic approach and identify parallelly. We have to send the investigations. Start with the depending upon the severity of his hemodynamics and organ involvement. We need to add. We presume that these are the possible infections and hit hard in a broad spectrum way. That's what I think.
Yes, sir.
So maybe I can say that there is a like tropical fever cocktail antibiotics like Falcigo, Doxy, and some third generation cephalosporin will cover all the 5 infections like strep typhus, malaria, leptospirosis. All the 3 will cover. Dengue doesn't require an antibiotic. And at the same time, parallelly, if the fever is not coming down, platelets are not improving, then the day level 2, we need to go for autoimmune investigations to identify non-infectious causes of the thrombocytopenia. And finally, bone marrow.
Yes, sir. Suppose if it's malaria and it will not it will not subside. Fever will not subside until we give a treatment. Identify the others, as you mentioned, cephalosporins, doxy, anta respond అవుతుంది.
This is doxy, Falcigo, and cephalosporin. Yeah, the combination of doxy, Falcigo, and cephalosporin. So cephalosporin will take care of lepto. Doxy and Falcigo will take care of complicated malaria. Doxy itself will take care of scrub typhus. So 3 infections are taken care. Dengue doesn't require antibiotic. 4th one is also indirectly covered, fluid resuscitation. And depending upon the recovery, we may extend our investigation the day 2, day 3 to evaluate the autoimmune vasculitis, SLE, those things, and TTP, HUS, all those things. Finally, we might come across unknown etiology, then bone marrow, and that also seems to be normal, then it is TTP.
సార్ ఇది మీరు ఫాల్సిగో మనకి యాజ్ సూన్ యాజ్ పాసిబుల్ మన హాస్పిటల్స్ లో వస్తాయి కదా సార్ మలేరియా. షుడ్ వి స్టార్ట్ ఈవెన్ ఇన్ క్లినిక్ ఆల్సో దే డూ మలేరియా టెస్ట్. షుడ్ వి స్టార్ట్ అండ్ ఫాల్సిగో యాజ్ సూన్ యాజ్ పాసిబుల్?
Actual గా it is not, sir. As per the
టెస్ట్ వచ్చిన
guidelines,
తర్వాత చేసుకోవచ్చు.
yeah, as per WHO guidelines, and even in Indian scenario also, it is a crime to start Falsigo on any patient without having a diagnosis positivity. That is the present recommendation. But still, we are
100% sir.
yeah, but still we are skeptical and we are in a fear complex. We start Falsigo. But guidelines
అంటే
says,
మోస్ట్ ఆఫ్ ద టైమ్ సార్ ఏమవుతుందంటే సమ్ ఆఫ్ ద ఓల్డ్ టైమ్ అండ్ న్యూ టైమ్ అయిన ఫిజిషియన్స్ స్టిల్ దే ఆర్ పుట్టింగ్ యాజ్ ఎ క్లినికల్ మలేరియా అని పెడుతున్నారు.
on sir.
బట్ ఐ థింక్ I don't accept with that things. As you mentioned, it is a crime to start on anti-malarials if the test is negative.
Without having a positive test, it is not supposed to be.
Yes, sir. Because there can be, see, parasite VNF, when we do a rapid diagnostic test, malaria may not be present, but it can be positive.
Yes, sir.
Because of the endemic area. But అది నెగిటివ్ ఉంది అంటే it is negative only. Because the parasite load is less also, we can identify with the rapid diagnostic test.
Sir. But practically speaking, how many leptopositives we have seen? But usually positivity, IgM, IgG takes 10 days to come positive. But we don't go with other investigations like, so better to start with one cephalosporin which covers lepto.
So, what we start on antibiotics, commonly those will cover leptovers when the patient comes to ICU.
So, true, sir. IgM will come positive after week.
1 week.
At least a week time you have to go. I have one patient, no, young female, came to me with fever, rash, and 22,000 platelets on the presentation. And then she was telling that history of 15 days of fever on and off, but never investigated. So 22,000 is alarming thing, and she's having rash and she's having a menstrual bleed. I'm a little bit worried and started giving platelets, and I worked up initial investigations or infective related investigations are negative. Then we send ANA profile, it came positive. And there are 3 subset, some ROLA, all these things are positive. So finally, we kept her for, I think it is SLE అనుకుంటా. తర్వాత రిడ్యూస్ మ్యాప్ అవన్నీ స్టార్ట్ చేసిన తర్వాత సస్టైనబుల్ ప్లేట్లెట్ కౌంట్ వచ్చింది. 15 days తర్వాత అగైన్ దెర్ ఇస్ ఎ డ్రాప్. స్టెరాయిడ్స్ ఇచ్చాను. తర్వాత మళ్ళీ ఇంటికి డిశ్చార్జ్ చేసిన 15 days లో మళ్ళీ 20,000 వచ్చింది. డిస్పైట్ షీజ్ ఆన్ సమ్ అజాథయోప్రిమ్ అది ఉంది. బోన్ మ్యారో చేస్తే నెగిటివ్ వచ్చింది. యంగ్ ఫిమేల్ కాబట్టి ఇనీషియల్ గానే వి థాట్ ఆఫ్ ఇట్ ఈస్ సంథింగ్ రిలేటెడ్ టు నాన్ ఇన్ఫెక్టియస్.
Definitely, sir. 15 days of having fever, and she might be showing to someone, and they might have used doxy, cephalosporins, ఇవన్నీ. సో ఇవన్నీ ట్రీట్ అయిపోతాయి. మలేరియా అయితే 15 days వరకు అంత ప్రొలాంగ్డ్ గా చేయదు. అది would have landed into some other organ failure. So definitely we need to even rule out that, but at the same time evaluate for other causes. And the issue with us here, we are not able to follow these patients. What is happening to them?
Luckily, she got admitted under me. She comes to me OP regularly.
అదే సార్, మీ కింద అడ్మిట్ అయింది కాబట్టి you are able to follow. But most of them don't admit the patient. So how this course, ఇప్పుడు మనం అక్యూట్ గా ఆర్గన్ ఫెయిల్యూర్ ట్రీట్ చేస్తాము, స్పెసిఫిక్ థెరపీ ఇచ్చి పంపిస్తాము. But how they are behaving in the community, how the treatment is responding అనేది తెలియదు సార్. అది primary disease.
And we have an extended one extra mile that I don't have a rheumatologist here. I send this patient to OP basis to Jubilee Apollo, took the rheumatologist opinion OP basis, brought her back, continued the same therapy what he has prescribed here.
Yes, sir.
అది Sir, anything from juniors or any other contributions?
Thank you, sir.
సార్ మరి ఇంకా 9 అవుతుంది సార్, అందరికి థ్యాంక్స్ చెప్తాను నేను.
వరలక్ష్మి మేడం, ఎనీ ఇన్పుట్స్?
ఉన్నారా మేడం?
మేడం ఉన్నారు. వరలక్ష్మి, శ్రీకాంత్, లక్ష్మీరాణి మేడం.
శ్రీకాంత్.
Sir, we'll sign off, sir. Thank you.
Yeah. Thank you all for your patient hearing and good discussion. And thanks.
Thank you, sir. బాగా లేట్ గా జాయిన్ అయ్యాను, అందుకని ఇంకేం
Thank you.
థ్యాంక్ యూ సార్.
శ్రీకాంత్ ఒక చిన్న డౌట్. గ్రూప్ డిస్కషన్ మొన్న ఎవరు రెస్పాండ్ అవ్వలేదు కానీ జీబీఎస్ పేషెంట్ కి ఎనీ రిలాక్సెంట్ ఆఫ్ చాయిస్ స్పెసిఫిక్ ఏమైనా ఉందా?
జీబీఎస్ పేషెంట్ గా సార్, అంటే జీబీఎస్ అని కాదు కానీ అంటే సిక్ కేసెస్ లో జనరల్ గా సిస్టెక్టెక్యులమ్ ప్రిఫర్ చేస్తున్నాను సార్.
అండర్స్టాండ్, బట్ దట్ ఈస్ ఓన్లీ ఫర్ హీమోడైనమిక్స్, బ్రాంకోస్పాజము. కానీ ఇక్కడ ఏంటంటే నాకు న్యూరోమస్కులర్ కండక్షన్ దగ్గర ఇంటర్ఫేర్ అయ్యేది ఉంది కదా, జీబీఎస్ ఇస్ ద సేమ్ డిసీజ్ కదా, నాకు అక్కడ దాని గురించి డౌట్
సార్. అంటే స్పెసిఫిక్ గా జీబీఎస్ రిలేటెడ్ ఐడియా లేదు సార్, బట్ ఎనీ న్యూరోమస్కులర్ డిసార్డర్స్ అవి ఉంటే జనరల్ గా అంటే వీ కెనాట్ అవాయిడ్ అనస్థీషియా కాబట్టి ఆ టైప్ ఆఫ్ కేసెస్ లో వీ యూస్ టు డాక్యుమెంట్ అండ్ యూస్ ద షార్ట్ యాక్టింగ్ వన్స్. ఎలిమినేషన్ హాఫ్ లైఫ్ అది తొందరగా ఉండేది. సో ఆ కేసెస్ లో అందుకనే సిస్టెక్టెక్యులమ్ ప్రిఫర్ చేసేవాళ్ళం సార్. మేబీ జీపీఎస్ లో కూడా ఐ థింక్ ఇట్ కెన్ బి ద చాయిస్ ఆఫ్ డ్రగ్.
సక్సమిథోనియం ఇస్ కాంట్రాఇండికేటెడ్.
సక్సమిథోనియం కాంట్రాఇండికేటెడ్ సార్. సక్సమిథోనియం కూడా వాడలేదు సార్ అసలు.
ఓకే సార్.
అంటే ర్యాపిడ్ సీక్వెన్స్ ఇండక్షన్ అవి చేసుకోవాలంటే ఇంకా రాక్రానియం వాడుతున్నాం సార్. ఇప్పుడు సుగమటెక్స్ బాగానే అవైలబుల్ గా ఉంది సార్.
ఇంటిబేట్ చేస్తేను తర్వాత ట్రెకాస్టమీ షిఫ్ట్ చేయాలి. షిఫ్ట్ చేయడానికి కొంచెం పేషెంట్ ఏమోని కంటిన్యూస్ గా బక్కింగ్ అనమాట. ఓన్లీ బల్బార్ ఒక్కటే ఉంది. సో అదర్వైజ్ మజిల్స్ చూస్తే వీక్ ఉన్నాయి కంప్లీట్ గా. 0/5 ఓవర్ బోత్ అప్పర్ లిమ్స్ అండ్ లోవర్ లిమ్స్, బట్ కాన్షియస్ విత్ బల్బార్ యాక్టివిటీస్. కంటిన్యూస్ గా బక్కింగ్ అగైన్స్ ద స్వాలోయింగ్ ఉంది.
డెఫినెట్లీ బెటర్ చాయిస్ సార్.
సరే ఓకే సార్, థ్యాంక్ యూ.
ఓకే థ్యాంక్స్. థ్యాంక్ యూ సార్.
Thank you, sir.